about the child with a fluid and electrolyte alteration. And by the end of this session, you should be able to discuss the regulatory mechanisms to maintain fluid and electrolyte balance, discuss the pathophysiology and nursing implications of a child with dehydration, diarrhea, and vomiting, and identify the different types of acid-base disturbances. To give you a little bit of a background, we want to first talk about infants and young children have a proportionally larger extracellular fluid volume. And we need to understand that the amount of fluid ingested during the day should equal amount of fluid lost through sensible water loss, which is the urine output, and insensible loss, which is respiratory tract in the skin. Body water is located within the cell. That's called the intracellular compartment. Body water that is located outside the cell is extracellular compartment. The extracellular fluid is located in the interstitial spaces that surrounds the cells. Intravascular fluid is within the blood vessels or plasma. And then you have transcellular, which is the cerebrospinal fluid, the pericardial fluid, pleural fluid, synovial fluid, sweat, and digestive secretions. A child is more likely to lose extracellular fluid than intracellular fluid. Extracellular fluid is lost first through trauma, illness, fever. Intracellular fluid is more difficult to dehydrate. Infants and children have proportionally greater body surface area in relation to body mass. This results in greater fluid loss through the skin and gastrointestinal tract. In neonates, 40% of body weight is located in the extracellular compartment compared to 20% of adolescent and adult. 50% of this extracellular fluid is exchanged daily in infants. Dehydration can occur very suddenly and rapidly if fluid intake is inadequate or fluid losses are excessive. Adults and older children have a greater proportion of fluid in the intracellular compartment, so severe fluid depletion does not occur rapidly. When we talk about body fluids, it's composed mainly of two elements, water and solutes. Water is the primary constituent. Neonates make up 75% of the infant's weight is water. Adults, 55 to 60% of weight is water. Solutes are composed of electrolytes and non-electrolytes, sodium, chloride, and potassium. Primary electrolytes in extracellular fluid is sodium. Extracellular space contains more sodium chloride during infancy, which makes them more vulnerable to electrolyte disturbances. Primary electrolyte in intracellular fluid is magnesium and potassium. We're going to talk about the maintenance of acid-base balance. We're going to talk about the chemical buffering, respiratory control of carbon dioxide, renal regulation of bicarbonate, and secretion of hydrogen ions. A normal pH is 7.35 to 7.45. This is important to maintain for cellular function, enzyme activity, and neuromuscular membrane potentials. Chemical buffers, respiratory system, and kidneys work together to keep the blood pH within the range. Acid is constantly produced as a byproduct of metabolism. Chemical buffers are consistent of bicarbonate and proteins. Bicarbonate is by far the most important buffer for plasma and interstitial fluid. It's responsible for most extracellular fluid buffering and exerts effects quickly. If alterations of the buffer system can't regulate itself, compensatory mechanisms from respiratory and the renal systems become activated. Respiratory works rapidly to compensate for the acid-base disturbance. Renal system works much slower to correct the imbalance, usually within 1 to 2 days. So when we say acidosis, we mean the pH is below 7.35. Therefore, the respiratory rate and depth will increase to remove carbon dioxide and raise the blood pH. Kidneys will excrete hydrogen ions and conserve bicarbonate to raise the blood pH. That's an acidosis. In alkalosis, the pH is above 7.45. Respiratory rate and depth decrease, lowering the blood pH. The kidneys are going to kick in and regulate the bicarbonate and remove hydrogen ions from the blood. If the blood is too alkaline, the kidneys start to conserve hydrogen ions, thus lowering the blood pH. If acidosis is present, kidneys will excrete hydrogen ions and conserve bicarbonate, raising the blood pH. Normal values to know: pH 7.35 to 7.45. Carbon dioxide 35 to 45. Bicarbonate 22 to 26. These you need to commit to memory in order to understand arterial blood gases. Now we're going to head at acid-base disturbances. We're going to go through each one of these: metabolic acidosis, respiratory acidosis, metabolic alkalosis, and respiratory alkalosis. I want you to focus here on the metabolic alkalosis and metabolic acidosis. I want you to know respiratory acidosis and respiratory alkalosis, but it's not imperative for this particular exam. You should know that they exist, but for the understanding for this lecture, I'm only going to be focusing mainly on metabolic acidosis and metabolic alkalosis. So when we talk about metabolic acidosis, some of the causes would be ketoacidosis, fever, acute and chronic renal failure, and diarrhea. Some values that you'll see on an arterial blood gas: the pH may be less than 7.35, the carbon dioxide is less than 40, bicarbonate less than 22, and the K, potassium, is greater than 4.0. So therefore, the blood pH and the bicarbonate levels will be below homeostatic levels, which is not where we want it. So what kicks in? The compensatory mechanism. So you begin to hyperventilate to rid the body of excess acid. Some signs and symptoms that you'll see of metabolic acidosis: increased heart rate, hyperventilation. You may find cold, clammy skin initially, but then the skin will then become dry and warm when acidosis worsens. Initially, the level of consciousness may be fatigue or weakness, but eventually stupor and coma will set in if left untreated. So the treatment for metabolic acidosis is bicarbonate, potassium, and mechanical ventilation if necessary. When we talk about metabolic alkalosis, some of the causes here would be vomiting, gastric drainage, diuretics, cystic fibrosis. Some values you'll see on an arterial blood gas: a pH of greater than 7.45, carbon dioxide of greater than 45, a bicarbonate level greater than 26. This constitutes a rising blood pH and bicarbonate levels. So for the compensatory mechanism to kick in to correct this alkalosis, the body is going to go into hypoventilation to allow for carbon dioxide to accumulate in the blood. Some clinical manifestations that you're going to see in metabolic alkalosis: increased heart rate, decreased respiratory rate and depth, muscle weakness. So to treat this, mild to moderate alkalosis is not necessarily requiring treatment. But if it gets worse than mild to moderate, use of fluids with sodium and potassium chloride often will correct this imbalance. When we talk about respiratory acidosis, some of the causes may be pulmonary disease or acute and chronic renal or respiratory failure. So on arterial blood gas, you will see a pH of less than 7.35, carbon dioxide of greater than 45, and a bicarbonate that will be within normal limits. So for the body to compensate, it will increase renal reabsorption of bicarbonate. Some clinical manifestations that you'll see: increased heart rate, increased rate and depth of respiration. Respiratory alkalosis, some causes here would be hyperventilation from a CNS stimulation, such as fear, emotions, pain level, or decreased lung compliance, such as an asthma or heart failure. Sepsis can also cause respiratory alkalosis. Values you'll see on an arterial blood gas: pH of greater than 7.45, carbon dioxide of less than 35, and a bicarbonate level that may be decreased. So, to compensate, you'll have a decreased renal reabsorption of bicarbonate. In signs and symptoms, you'll see dizziness, lightheadedness, diaphoresis. Oftentimes, this is just respiratory alkalosis will resolve on its own and won't require any medical management. So the treatment goals in acid-base balance is really to treat the underlying problem of the metabolic acid-base disturbance. That will correct the alkalosis or acidosis. If the treatment of respiratory imbalance is directed toward reestablishing alveolar ventilation, so it's really the respiratory support is your treatment measure for respiratory imbalance. We're going to talk now about types of dehydration. There are three types: hypernatremic, hyponatremic, or isonatremic. Hypernatremic is when the water loss is greater than the electrolyte loss and the sodium level is greater than 150 milliequivalents per liter. And this can occur from osmotic diuretics, diabetes insipidus, diabetes mellitus, vomiting, diarrhea, fever, increased sodium in formula, diet, or tube feeding, IV fluids, burns, ineffective breastfeeding. Some of the clinical manifestations you're going to see: increased thirst, fair skin turgor, thickened skin turgor, decreased urine output, parched mucous membranes, skin temperature cold or hot, febrile or not, lethargy, and hyperirritable. When we talk about hyponatremic, sodium concentration is below that of a normal body fluid. So it results in a concentration of sodium less than 135 milliequivalents per liter. Some of these causes may be renal losses, such as diuretics, hyperglycemia, nephritis, adrenal insufficiency, vomiting, diarrhea, third spacing, burns, tube drainage, SIADH, nephrosis, electrolyte-free solutions during illness. So some clinical manifestations you may see in this is increased thirst, poor skin turgor, clammy skin, decreased urine output, mucous membranes dry to slightly moist, cold skin temperature, and very lethargic. They may or may not have a fever. Isonatremic is the most common type of dehydration in children, and sodium concentration is practically identical to that of body fluids and is the most common form. So electrolytes are lost in the same proportion as they exist in the body. Serum sodium levels remain within normal limits. Vomiting and diarrhea and sensible loss from respiratory and integumentary systems are the causes. Some clinical manifestations that you'll see with isonatremic dehydration: mild thirst, skin turgor is poor, dry skin, decreased urine output, dry mucous membranes, skin temperature is cold, they may or may not have a fever, and they may be lethargic. So key factors in diagnosing dehydration is the assessment, the intake and output, vital signs, level of activity. And before I get into what constitutes mild dehydration, moderate dehydration, and severe dehydration, I'm going to talk about physical assessment that goes along with the key factors in diagnosing dehydration. So when you're assessing a baby or infant or child, weight is the crucial indicator of fluid status. Changes in weight during illness may indicate fluid retention or pulmonary or generalized edema. Assess for pulmonary crackles and periorbital edema. Skin and mucous membranes. Assess the color, temperature, and turgor. Turgor meaning the elasticity of the skin, moisture and capillary refill. Mucous membranes and presence of tears. Dry or sticky mucous membranes in the absence of tears are an indication of dehydration. Absence of tears is not significant in an infant younger than 2 to 3 months of age because they don't manufacture tears at that age. Sweating and estimate dampness from clothes and linen. When we look at the vital signs, fever increases the metabolic rate and fluid requirements. Pulse can be rapid, weak, or thready with dehydration. Increase in respiratory rate compensating for metabolic acidosis accompanies dehydration. Blood pressure may be decreased in moderate and severe dehydration. This is a late sign of hypovolemia. Urine output is something that you need to know in terms of the values for a minimum urine output. When we talk about infants and toddlers, 2 to 3 milliliters per kilo per hour is the minimum urine output requirement. When we're talking about preschoolers and young school-age children, it's 1 to 2 milliliters per kilo per hour. When we talk about school-age children or adolescents, 0.5 to 1 milliliter per kilo per hour is the minimum urine output that they should have to maintain fluid requirements, fluid and body requirements, fluid volume requirements. Usually specific gravity is greater than 1020. We'll also see fontanelles, the interior fontanelle, to be sunken or depressed. The cranial suture lines may also become prominent with dehydration. You want to assess the stools and the vomitus, the frequency of them, the type, the amounts, the consistency. We want to assess the electrolytes, so we're going to get a complete metabolic panel on this patient. And assessing behavior. Are they irritable? Are they lethargic? Are they confused? Are they having a seizure? This all may be present in dehydration. Do they have a high-pitched cry, or is it weak? So when we talk about signs and symptoms of dehydration, we're going to talk about fewer wet diapers than usual. And we need to weigh those diapers every time the baby's changed. We talk again about no tears when crying, inside of mouth dry and sticky, lethargy, poor skin turgor, increased respiratory rate, sunken fontanelle, abnormal skin color and temperature. So I want to talk again about the causes of diarrhea. So viral gastroenteritis is the major cause of diarrhea in children older than 1 year of age. Rotavirus infection and norovirus are also most common. However, the rotavirus vaccine is now being given to children, so that should minimize that occurrence. Most of the time, diarrhea is caused by an infection called gastroenteritis. And some signs and symptoms that you'll see of this is dry, hot skin, changes in skin turgor. The small intestines will have cramping and nausea and vomiting. The large intestines will have voluminous stools, light in color, loose to watery in texture, and very foul smelling. So to diagnose diarrhea, to see if whether this is viral or bacterial or some other cause, we're going to take some stool cultures. And we're going to assess it for bacteria, over and parasites. We're also going to check the blood. We're going to check it for rotavirus and norovirus in the stool. Blood tests that we'll do is a CBC. We'll do electrolytes, BUN, and blood cultures. So the treatment for diarrhea is to prevent the spread of infection. So good hand washing is paramount. You want to continue feeding a normal diet that can prevent dehydration and reduce stool frequency and volume and hasten recovery. So some of those things to consider. Giving the child complex carbohydrates, rice, wheat, potatoes, cereal, yogurt, cooked vegetables, lean meats. The brat diet, which consisted of bananas, rice, applesauce, and toast, was once the forefront with utilizing this diet for diarrhea. But it's gone out of favor, and that's because it's low in energy, in density, in fat, and protein. So it's not recommended as much anymore. You want to start refeeding the child with solids and formula once rehydration occurs. So, really pushing the fluids, the hydration, is going to be important before the solids come into play. If the child has a bacterial cause for his diarrhea, you're going to treat with antibiotics to get rid of that infection. When we talk about caring for the child who is vomiting, you want to observe and report the vomiting, assess for associated problems such as dehydration. You want to implement measures to reduce the vomiting, record accurate intake and output, and evaluate the effectiveness of therapy and prevent aspiration. So when we talk about vomiting, the etiology can be serious, many things. It can be infection, it can be obstruction, it can be metabolic alterations or allergies. If associated with diarrhea, most likely it's related to gastroenteritis. So the manifestations of vomiting can be regurgitation caused by overfeeding. It could be forceful vomiting due to obstruction, projectile vomiting caused by obstruction, or continuous vomiting in the absence of diarrhea can contribute to metabolic alkalosis. So to diagnose the underlying problem for the vomiting, you want to get a CBC and electrolytes, BUN, glucose level, and blood cultures. Management is with oral rehydration therapy, is used to treat vomiting and diarrhea. And when I'm going to talk more now about oral rehydration therapy, and it's really all going to depend upon whether the child has mild, moderate, or severe dehydration with what you use for treatment. So when we talk about mild dehydration, it's less than 5% of body weight loss. And what we recommend is to continue to breastfeed or continue the age-appropriate diet along with fluid replacement. And that fluid replacement would be replaced with an oral rehydration solution, ORS. And examples of this would be Rehydrolate or Pedialyte. We recommend no apple juice because that can aggravate diarrhea and increase fluid loss. Sports drinks are not the best solution due to the high percentage of sugars and carbohydrates. When we talk about moderate dehydration, we're talking about 5 to 10% loss of body weight. The treatment here is 50 to 100 milliliters per kilo of fluid required, plus the replacement of continuous losses over a 3 to 4 hour period. Continuous losses is the losses of the vomiting and the diarrhea that are ongoing. So not only do you want to replace the normal fluid requirement of the child, but you want to replace those extra losses from the vomiting and diarrhea. So continuous losses, you're going to go with 60 to 120 milliliters of oral rehydration solution for a child weighing less than 10 kilos. For a child weighing more than 10 kilos, you're going to give 120 to 240 milliliters. And this is to replace the loss from each episode of diarrhea or vomiting. And it's given over a 3 to 4 hour period, in addition to the regular fluid requirement of the child's based on the child's weight. So let's say the child weighs, 10 kilos. You're going to base your fluid requirement on how much a child of 10 kilos needs per 24-hour period. Over and above that, you're going to replace the continuous losses from the vomiting and diarrhea with 60 to 120 milliliters over 3 to 4 hour period to help rehydrate the infant or child. We want to continue to breastfeed as long as it's tolerated, and we want to resume a regular diet once dehydration is resolved. When we talk about severe dehydration, this is greater than 10% of body weight. The treatment here is parental fluid and electrolytes. Initially, you typically give lactated ringers or normal saline in bolus form of 20 milliliters per kilo or 10 milliliters per kilo until hydration improves. Once urine output is adequate, then you can add in electrolytes in the IV fluids, such as potassium, if necessary, to improve electrolyte imbalances. You only replace potassium if the urine output is adequate. If it is not adequate, you should not be adding in potassium into the IV fluids because it can damage the function of the kidneys. Here is a case study. Daniel is a 3-month-old and brought to the clinic for not taking his formula and crying continuously. The subjective data is watery stool for 2 days, cannot tell if it's urine in it, doesn't want to eat his formula, cries all the time, and mother can't get him to stop. No tears when he cries. Has had a fever, no thermometer to take temperature, he felt warm. Here's your objective data. He's lethargic, he's pale, he's got a sunken fontanelle, his stool is watery with flecks of green and brown, his temperature is 102.2 degrees rectally. Pulse is 152 beats per minute and his respiration is 65 breaths per minute. What is a primary concern for this infant? Number 2, what laboratory work would you expect to be done for this child? 3, what can the mother do in the future to help treat this condition at home? The primary concern, especially being an infant, is the extracellular fluid loss. Because they have a greater proportion of body surface area in relation to body mass, they can have a greater fluid loss through the skin and gastrointestinal tract, therefore making dehydration occur much more quickly and severely. So what are we going to do for him? So he needs to get an IV started and a bolus of IV fluids given. We're going to replace his electrolytes, or at least check his electrolytes first, of sodium, potassium, and chloride. Take blood cultures to check for blood infection, urine, and stool samples for cultures and analysis, and a possible lumbar puncture to rule out any other cause that may be the reason for his diarrhea. Understand what can cause a child to become dehydration is what you want to explain to the mother. In anticipatory guidance, you want to educate the mother on vomiting and diarrhea and what she can do at home for him prior to coming in to the clinic. Once you educate the mother about what causes vomiting and diarrhea, what to look for, the signs and symptoms to look for, like decreased urine output in the diapers, being lethargic, not really drinking very much of either breast milk or formula, we can start to teach the mother different ways to help compensate, which is giving Pedialyte at home in small amounts can be started. If the vomiting and diarrhea continues for more than 24 hours, then she needs to be seen by the pediatrician. But starting at incremental doses of Pedialyte in small increments um, to assess if the baby can hold it down and to help rehydrate may be enough to minimize the need to have to go to the pediatrician's office. Obviously, we're going to go over if the fever is over 101.5, over 100.5, we want to have them be seen anyway by the pediatrician because of the fact that it's 100.5 and over, they should be seen. Any infant under than 3 months of age, 0 to 3 months, needs to come in for an evaluation to rule out any other cause related to the fever. So this child would, or this infant, I should say, would be seen anyway in the clinic. But to get started with rehydration, the mother can start using Rehydrolyte or Pedialyte at home before coming into the clinic. But he should be seen. His fever should come down with a Tylenol, and then IV, because this is a kid who probably isn't going to hydrate on his own completely, so that's why an IV needs to be started and a bolus needs to be given, usually 10 per kilo of a bolus of fluid. And then you're going to recheck his electrolytes after the fluid boluses have started to see if his electrolyte imbalance has improved.